Imagine a patient walks into the ER and their skin looks exactly like a severe scald burn. I mean, just peeling off in these massive weeping sheets.
Oh, yeah. That is a terrifying presentation to walk into.
Right. And your first instinct, as a surgical resident, is probably to prep for massive fluid resuscitation and start planning your surgical debridement.
Which is a completely logical reflex, honestly.
It is, but if you make the wrong call here, if you confuse an internal immune disaster with a bacterial exotoxin, your intervention could literally be fatal. So, welcome to this deep dive. We are two plastic surgeons, and we are getting straight to the facts today with a really rigorous question and explanation review of thermal cold injuries and pathological skin loss syndromes.
Yeah, this is high-yield material designed specifically for your FRCS board exams. We are skipping all the fluff today. We're focusing purely on the pathology and the management protocols that you actually need to know. Time is your most valuable asset right now, so our goal is to optimize your revision by, really breaking down the mechanisms behind these clinical presentations.
Spot on. We're going to explore that threshold of tissue viability, from external environmental destruction to complete systemic failures. But before we start the clock on the clinical material, just two quick things. First, hit follow on your app and rate the show right now if you find this structured review valuable for your prep.
Yeah, please do. It really helps.
And second, get a premium subscription. That gives you exclusive access to our journal club and clinical cases deep dives, which, let's be honest, are absolutely essential for mastering the application of this knowledge for the boards.
You really can't skip the clinical cases if you want to pass.
Definitely not. Okay, let's dive in. Let's begin with the most direct form of thermal injury by heat removal, which is freezing. Understanding the cellular destruction here kind of sets the baseline for evaluating all the tissue viability we're going to discuss today.
Right.
So let's start with the basics. We're classifying these cleanly into freezing and non-freezing injuries, right?
We are, yeah. Fundamentally, a cold injury is just a thermal injury where heat energy is removed from the body rather than added. So the mildest form of a freezing injury is frostnip.
That's your classic ski slope injury, right?
Exactly. It's going to hit those exposed acral regions first. So we're talking about the tip of the nose, the ears, the fingers, and the toes.
And clinically, frostnip presents as this white, insensate skin. But the defining feature here, and what you really need to separate it from true frostbite for the exam, is what happens when you warm it up.
Yeah, upon simple rewarming, the skin becomes hyperemic, and the patient gets intense paresthesia.
Like that horrible pins and needles feeling.
Exactly. It's painful, but full recovery is the rule. There is absolutely no permanent tissue loss with frostnip.
Okay, so it's basically a temporary physiological shutdown, not structural destruction.
Precisely. But when the temperature drops further, hitting 0 degrees Celsius, that's when we cross the threshold into actual frostbite.
Okay, let's unpack this mechanism, because this is where the exam questions love to dig in. Is frostbite essentially just like freezing a water pipe until it bursts? Like the ice expands and just physically shatters the cell?
You'd think it's just the ice crystals physically piercing the cell like little needles.
Right.
But it's actually much more insidious than that. It's a profound chemical unraveling.
Oh, wow. Okay, how so?
Well, as the skin cools to 0 degrees, ice crystals do form, but they form in the extracellular space first.
Right, so the fluid outside the cell freezes. That has to change the osmotic gradient entirely.
Exactly. Those extracellular ice crystals actively draw water out of the cells. So the cell isn't just sitting next to ice, it is actively desiccating.
Wait, really? So the cell is basically dehydrating to death while completely surrounded by frozen water?
Yeah, it's a brutal irony. That massive loss of intracellular water leads to severe intracellular hyperosmolarity, which then causes massive protein denaturation.
And that's the true cellular killer.
It is. It's a dual mechanism. You have the physical crystal damage on the outside and these severe osmotic shifts on the inside. And simultaneously, your body is desperately shunting peripheral blood away from the extremities to maintain your core temperature.
Right, the survival mechanism kicking in.
Exactly. But that peripheral shunting causes severe localized ischemia,
which triggers microvascular endothelial damage, so the blood vessels themselves get injured, leading to vascular stasis. And if that microvasculature doesn't recover during rewarming, you're looking at inevitable thrombosis and subsequent gangrene.
Which brings us directly to the management sequence. This is highly testable. When a patient presents with severe frostbite, the absolute first step is a full ATLS survey.
Right, airway, breathing, circulation.
Yes. You have to treat the systemic hypothermia first. I cannot stress this enough. Do not get distracted by the frozen hand or foot until the patient's core temperature is totally stabilized.
That's a classic trap on the exam. So once the core is stable and we're ready to address the extremity, the gold standard is rewarming in a circulating water bath, right?
Yes, set exactly between 37 and 39 degrees Celsius for up to 1 hour.
But what is the precise clinical endpoint? Because we aren't just staring at a clock.
No, you're constantly watching the tissue. The endpoint of rewarming is when a distinct red-purple color appears and the soft tissues become pliable again.
Makes sense.
And once you achieve that, the limb must be rigorously protected. We're talking about preventing literally any minor mechanical trauma and administering strict infection prophylaxis.
And for medical adjuncts, we're giving ibuprofen. But for revision purposes, you really need to remember we aren't just giving it for analgesia here. Ibuprofen specifically targets that inflammatory cascade we just talked about.
Absolutely, it's an antiprostaglandin agent. We also need to consider thrombolytic therapy to combat that microvascular thrombosis.
All right.
There is really solid evidence for thrombolytics if they're administered early enough. Surgically, you might also need to perform a fasciotomy if compartment pressures rise during that massive reperfusion phase.
But here is the absolute golden rule for your boards regarding frostbite. You have to know this. Amputation is almost always delayed until tissue demarcation is entirely complete.
Oh, yes. Frostbite in January, amputate in July. That's the old adage.
Right. Because tissues that look completely dead on day 2 might totally declare themselves viable by day 20. You wait. You never, ever rush to debride frostbite.
Never.
So we've seen how freezing temperatures cause direct structural and osmotic damage. Let's pivot slightly to environments that don't quite reach 0 degrees, but still manage to cause severe, unique tissue necrosis.
Right, we're talking about the non-freezing cold injuries, and the classic paradigm here is trench foot.
Trench foot is one of those things that sounds almost quaint, like historical trivia from World War I, until you actually see it in a civilian who's been living rough, or maybe a soldier on prolonged exercises.
Yeah, it is still very much around. It's caused by this perfect storm of near-freezing temperatures, a constantly wet environment, limb dependency, and constriction by tight shoes or clothing.
That specific combination is highly destructive. And the pathology it causes is this superficial, moist, liquefactive necrosis.
Yes.
But here's where it gets really interesting for the pathology nerds. If there are no ice crystals physically destroying the cell membranes, and there are no massive osmotic shifts dehydrating the cell, why on earth does this end up as liquefactive necrosis? Is it purely just prolonged microvascular strangulation?
Yes, it's exactly that. It is a slow, suffocating death of the microvasculature. The wet and cold environment forces prolonged vasoconstriction. The dependency of the limb prevents proper venous return.
Like pooling blood.
Exactly. And then those tight, wet boots act literally like a tourniquet. So you are starving the tissues of oxygen for days on end, which drives this really prolonged ischemic cascade, resulting in that liquefactive necrosis.
Wow. Okay, for the exams, we need to break down the pathogenesis of trench foot into 3 overlapping phases. Let's walk through the timeline, starting with the prehyperemic phase.
Okay, so the prehyperemic phase lasts from hours to days, while oxygen is still actually in that wet, cold environment. The limb is cold, it's swollen, discolored, and completely numb.
Right.
This is the period of intense vasoconstriction and the primary ischemic insult.
Then, once they are rescued and rewarmed, the microvasculature aggressively overreacts. Which brings us to the second phase, the hyperemic phase, which lasts about 2 to 6 weeks.
Yeah, this is essentially a massive reperfusion injury. The limb shifts dramatically, it becomes bright red, severely swollen, and features a really bounding circulation. The inflammatory cascade is just an absolute overdrive here.
And finally, we enter the third phase, the post-hyperemic phase, which can frankly last weeks or even months. The swelling goes down and the limb remains warm, but the patient suffers from profound cold insensitivity.
Yeah, and that cold insensitivity is the hallmark of the permanent nerve and microvascular damage sustained during that initial insult. As for treatment, it is entirely supportive.
Right.
You wash and air dry the feet, you institute cautious, slow rewarming, strict bed rest, and elevation to manage that hyperemic swelling.
Okay, so we've seen how the external environment slowly suffocates the microvasculature in trench foot and how freezing destroys it osmotically in frostbite. But what happens when the call is coming from inside the house?
Oh, this is the scary stuff.
Truly, when a simple medication triggers your own immune system to instantly obliterate your skin barrier.
We are shifting to toxic epidermal necrolysis, or 10N, and Stevens-Johnson syndrome, SJS. These are rare, acute, and potentially fatal immune-mediated skin reactions.
And they're characterized by massive, sheet-like skin and mucosal loss. These patients look exactly like severe partial thickness burn victims, and they require urgent burn unit management.
Absolutely. Let's talk triggers. Most cases are drug-induced. For your FRCS, the common culprits you really must memorize are allopurinol, cotrimoxazole, anticonvulsants, and NSAIDs.
Right, those are the big four.
There are also rare non-drug causes, like mycoplasma infections and certain vaccinations, and you must be aware of the genetic link.
The HLA mutations.
Yes, there is a heavy association with specific HLA mutations, particularly in Han Chinese populations.
And the fact that this is an immune-mediated pathogenesis is proven by the re-challenge phenomenon, right?
Yeah.
Like, if the patient survives and is later reintroduced to that exact same drug, the massive reaction just rapidly recurs.
Exactly. The immune system is basically primed and waiting for it.
So when they first present, we initially see these erythematous macules. Then we check for the Nikulsky sign, where you apply slight lateral pressure to the skin, and the epidermis just shears right off.
Yeah, a positive Nikulsky sign is your massive red flag, because within hours, those macules progress to overwhelming epidermal detachment and blistering, and crucially, it's not just the skin.
Right, the mucosa.
It aggressively involves mucosal surfaces.
Yes.
The eyes, the mouth, the esophagus, the upper respiratory tract, the genitourinary tract, the GI tract, everything.
It's horrific. So what does this all mean for our triage on the floor? Say I have a patient with 8% total body surface area involvement. I'm diagnosing SJS. But if they cross that 35% threshold, we're officially in 10 territory. Is differentiating them strictly a mathematical game of measuring TBSA, or are there underlying pathological differences?
For your exams, you must be absolutely clear on this. It is strictly a mathematical game of TBSA. SJS and 10 are just the milder and more severe ends of the exact same disease spectrum.
Because the histopathology is absolutely identical in both.
Exactly.
Under the microscope, you're looking at full-thickness keratinocyte apoptosis and necrosis of all the epidermal layers.
Yeah, the entire cellular population of the epidermis is dying simultaneously. That complete cell death is what destroys the adhesion to the dermis, causing those massive sheets of skin to detach.
So the diagnostic cutoffs are pure numbers. SJS is under 10% TBSA. TENS is over 35% TBSA. And if the patient has between 10 and 35% involvement, it's just classified as an SJS-10 overlap.
Correct. And once we have the diagnosis, we have to prognosticate. The Scorton criteria is the validated illness severity score you'll use to predict mortality risk.
Right, and this isn't just a random list to memorize. For you listening right now, think of this in 3 logical buckets to help you remember: your baseline vulnerability, your body's stress response, and your metabolic failure.
That's the perfect way to group them. There are 7 criteria in Scorton, each worth 1 point. First, your baseline vulnerability. That's age greater than 40 years and the presence of a malignancy.
Okay, second bucket, the body's acute stress response. That's a heart rate greater than 120 beats per minute and an initial epidermal detachment greater than 10% TBSA.
And the third bucket, representing renal and metabolic failure due to those massive fluid shifts. That's serum urea greater than 10 millimoles per liter, serum glucose greater than 14 millimoles per liter, and serum bicarbonate less than 20 millimoles per liter.
That drop in bicarb is key, right? Because it shows the patient is sliding into a metabolic acidosis from the profound systemic insult.
Yes, exactly.
So what do these scores actually mean for mortality?
The jump is terrifying. A Scorton of 1 predicts a 3.2% mortality, but if the patient hits a score of 5 or greater,
Wow.
yeah, the predicted mortality skyrockets to over 90%. Any patient scoring 3 or higher requires immediate management in an intensive therapy unit.
Let's talk management protocols. Step 1, identify and stop the offending drug. Step 2, calculate the Scorton. Step 3 is where the board exams will really test your logistical knowledge.
Yeah, step 3 is immediate transfer to a specialized burn unit. The statistics here really dictate our entire triage protocol. Survival rates are dramatically higher if the patient is transferred within 7 days of onset.
What are the numbers on that?
You're looking at a 51.4% survival rate with early transfer versus just 29.8% if they are delayed.
That is a massive difference. Once they arrive at the burn unit, they need an urgent ophthalmology review because that mucosal involvement can permanently destroy their vision. After that, it's aggressive fluid and electrolyte balance, managing them almost identically to a major thermal burn.
Wound care, however, remains highly controversial. Do we aggressively debride the blisters, or do we leave them as a biological dressing? There is no universal agreement on this.
Right. Some units swear by synthetic dressings like BioBrain, which seems theoretically ideal to cover the massive exposed dermis. But practically, it carries a really high risk of trapping infection, and epidermolysis often just continues to progress underneath it.
Exactly. It's a tough call.
And what about systemic therapies? Like, can we give them something to just switch off this immune cascade?
Well, it's heavily debated. No single intervention is universally proven to halt TEN or SJS. Teams will often try intravenous immunoglobulin or maybe cyclosporin, anti-TNF alpha antibodies, or even plasmapheresis to filter out the inflammatory mediators. But the evidence remains really mixed.
Even if our patient survives this acute intensive care phase, we have to talk about the aftermath. The long-term morbidity is just staggering.
Over 50% of survivors suffer severe long-term complications. The ocular damage is often the most devastating. Patients develop symblepharon, which is where the eyelid literally fuses to the eyeball. They get conjunctival synechia and entropion with trichiasis, meaning the eyelid turns inward and the eyelashes constantly scrape the cornea.
Cutaneously, they are left with extensive scarring and irregular pigmentation. The mucosal destruction causes persistent erosions, phimosis, vaginal synechia, diffuse hair loss, nail dystrophy. I mean, it is a total systemic catastrophe.
Which is exactly why you cannot afford to misdiagnose it.
Right. Which brings us to the ultimate clinical mimic. You have a patient who comes in with red, aggressively blistering skin. It looks identical to a massive scald burn or early 10. But the etiology and, crucially, the anatomical depth are vastly different.
We're talking about staphylococcal scalded skin syndrome, or SSSS.
Let's break down the pathophysiology here. We know TEN is a massive immune response destroying the entire epidermis. But SSSS is a targeted bacterial strike. It's caused by staphylococcal exfoliative toxins A and B.
Exactly. These toxins act as highly specific proteases. Their entire biological purpose is to enzymatically cleave the proteins that maintain desmosomes.
And desmosomes are the microscopic, cellular glue binding epidermal cells to one another. So we think about the skin like a house. TEN is a massive earthquake. It destroys the entire subepidermal foundation. The whole house collapses.
That's a great way to visualize full-thickness necrosis, but SSSS toxins only cleave the superficial desmosomes.
Got it. So it's shallow. SSSS is just a bad storm blowing the roof tiles off. The superficial layer peels away, but the actual foundation, the basal layer of the epidermis, is perfectly fine.
Exactly. That depth distinction explains the entire clinical picture. If the staph toxins remain localized, they just cause bullous impetigo. But if those toxins disseminate systemically through the bloodstream, they blow the roof tiles off everywhere, causing the widespread blistering of SSS.
Who is our typical patient for SSS?
It predominantly strikes children under 5 years old, particularly neonates, because the renal clearance of the toxin is immature. In kids, the mortality risk is quite low, around 5%.
Right.
But be warned, if an adult with significant comorbidities contracts SSSS, their mortality can reach 60%.
Wow. So you have a patient with massive blistering. It could be 10N, which requires burn unit transfer and carries terrifying mortality, or it could be SSS, which is relatively superficial.
Yeah.
How do we definitively diagnose SSSS to avoid putting them through the wrong massive interventions?
The gold standard for definitive diagnosis is the histology of a frozen section of the blister roof. SSS features strictly superficial epidermal blistering with a completely intact basal layer. 10N and SJS will show subepidermal blistering packed with completely necrotic keratinocytes.
Because the foundation is destroyed in 10, but only the roof tiles are cleaved in SSS.
Precisely. And because that deep basal epidermal layer remains completely healthy in SSSS, the management is far less invasive. It's purely supportive care combined with targeted anti-staphylococcal antibiotics like intravenous flucloxacillin.
And what's the recovery timeline for that?
Because the regenerative basal cells are still intact, recovery is incredibly rapid. Complete epidermal healing is usually expected within a week without the devastating scarring or mucosal fusion we see in TEN.
That's a massive contrast.
Right.
Well, we've covered a huge amount of ground today, and we connect this all to the better picture. There is a really profound unifying concept you need to take into your exams.
Absolutely. Whether we are talking about extracellular ice crystals physically dehydrating cells in frostbite, or the wet, constrictive environment driving microvascular strangulation in trench foot.
Or even systemic exfoliative toxins, enzymatically cleaving your desmosomes in SSSS.
Right. The ultimate failure mechanism of the skin barrier always hinges on two things: microvascular stasis and the physical breakdown of cellular adhesion.
It always comes down to the blood supply and the cellular glue.
Always. Understanding those shared microscopic endpoints is the true key to mastering reconstructive pathology. The clinical presentation might vary wildly, from a white insensate skier's ear to a widespread blistering mimic, but the cellular battleground is essentially identical.
That is exactly the level of synthesis you need for the boards. To everyone listening, we want to hear directly from you as you push forward in your revision. Go into the feedback or comment section of your podcast platform right now. Drop a comment telling us which of these pathologies, freezing injuries, trench foot, TPN, or SSS, do you find the most conceptually challenging to differentiate? Leave your questions there, keep grinding through the material, and we will see you on the next deep dive.